First way, free anchorage. For this case, I will show you the case of Lena. When you look at Lena, she's a nice Danish girl, but she isn't perfect. When you look at her, especially three-quarter, you can start to notice she's got a very slight lip incompetence. You can see that more in detail. You can see that there is not really a good definition. There is a bit of strain of the mentalis muscle when she's got to close the lips together. Which means that in a patient like this, that has got also a short, rather short ramus height, so a general pattern of vertical growth, you want definitely to avoid any kind of opening, bite opening mechanics. Because if you've got a patient that has got already to fight to close her lips, and you put in a mechanic that is going to open the bite and therefore to separate even more the mandible from the maxilla, you will go to worsen the lip closure and to worsen her facial appearance, therefore. So, what is one possible solution? Since the patient has got also quite a relevant amount of crowding, it was decided to perform extractions. When you're going to extract, one thing that you can do, you can use the teeth that you're going to extract to level the second molar before extraction. Because anyway, what happened to this tooth and this tooth, you don't care, because they will be extracted. So this is the concept of free anchorage. When you've got teeth that are going to be extracted, you can use them before extraction to do other movements, because they are free anchorage. You get something for free for once in life. So this was done, and after a period, it's of course a minor movement. You can see the difference that this is an intrusive movement, and we don't care what happened as a reciprocal effect to the premolar, because the premolar is going to be extracted. When you do this, you have to take care that in the upper arch, you have, as you can see, a transpalatal bar with segments that are going to prevent the upper second molars from erupting. Because if you are intruding the lower second molar and you don't do anything about the upper second molar, you risk that they will follow, so they will extrude. After this, it becomes a normal treatment with normal extraction mechanics to come to a result, an occlusal result that is acceptable. What is interesting to see is what is the extraoral result. This is an extraction case, and what you can see is that the smile is rather wide, so there is not any black corridors like normally you can hear in extraction cases. But what is more interesting is to see what happens to the profile of the patient. Normally you hear that when you extract, you tend to flatten the profile of the patient, you tend to worsen the lips. But what do you think? When you look at this, especially the upper lip, because the lower lip of course has improved because we have been reducing the face height, but even the upper lip, this one is more flat than this one. The lip after extraction treatment has got a better anterior curl. This is due to the fact that when you are able to control the vertical and therefore try to induce an anterior rotation of the mandible, you will tend to reduce the anterior face height, and therefore the soft tissue will be like squeezed, for which you tend to increase the curl, which in a patient that had strain and therefore very flat lips, it's beneficial. We can also see that what happened in the superimposition made on the stable structure on the mandible. This is a control 2 years after the end of treatment, in which there is post-treatment stability, and this is due to the fact that there is an adequate, among other things, an adequate amount of overbite. The question is, of course, do we extract in all patients? And of course we don't. So what do we do if we don't have the luxus of free anchorage, if we don't have 2 premolars to spend? How can we level our over-erupted lower second molar? One of the possible ways is to use bite blocks. For this one, I will have the help of this patient, it's called Larena, and she came to my observation. And you can see also in Larena, especially when you look at this picture, you can see in the detail there is very much strain. This means that she's got to fight to close the lips, and this means that the upper and the lower lip, they lack of definition. Normally, you would like to have in the lower lip a curl, like an S. Here is just flat. And also the upper lip is rather flat. So she's a patient that she's in a condition of strain. So you don't want to open up more her bite, because otherwise you will worsen this, and she will get even more strain during closure. When you look at the numbers of the cephalometry, you see that she's got, again, a rather short ramus. And a short ramus height is an indicator for possible posterior rotation of the mandible during growth. So, it's a patient that has got strain, is growing posteriorly, for which you want definitely to do anything you can to control the vertical. Unfortunately, when you look intraorally, you can also see that she's got a rather marked step between the second and the first molar. And this is due also to the fact that in one side on the upper arch, she had an extracted first molar, and therefore a second molar erupted in the place of the first molar. But during that time, the lower second molars, they had time to over-erupt and create a step. So how do you want to level this step? The answer is that in a patient like this, when you start, you can put fixed appliance in the upper, you can start to level the second molar and the first molar in the lower, just with a segment of rectangular night eye. But now you can ask me, okay, but this is exactly the situation that you showed us before. If we do this, we are into a geometry 1 or 2, for which we will tend to get this bad effect that we saw before. But this is when you have to use what is called a centric bite blocks. A centric bite blocks is a removable appliance that the patient wears full time, apart from when eating, is built in articulator, for which there is occlusion on the first molar and the premolar, so that the first molar is kept down, so there is no extrusion of the first molar and there is only intrusion of the second molar. This is not belonging to the patient that I show you, it's just a model to show you the appliance. It's important to build it in articulator if you don't want to use 1 hour on the chair to grind acrylic, which is not one of my favorite hobbies, so I would like to avoid it. After this goes on like a normal treatment. But you can observe that still there is a lack of intercuspidation. She didn't open up, but we are not satisfied about this. So what do you do now? You start to use vertical elastics, then you have to be afraid that the nun with the stick come to you. So you don't want to do that. There must be another solution. One of the things that you have to do in all patients, that I advise you, and if you want to take away something from this lecture, is take impressions of patients, of the teeth of patients during treatment, because you can see things that otherwise you couldn't see. All my patients get brackets placed with indirect bonding, so it's a very precise method, but despite that, look at the amount of bracket that had to be repositioned. When I saw this, I thought that my technician was drunk the day that she made the indirect bonding for the patient, but she wasn't. It's rather normal to have to reposition so many brackets, because some brackets you simply cannot place correct from the start due to the fact that, for example, premolars can be under-erupted. So you've got to make a repositioning, and the bite improves a lot, but still we have a problem. For example, one of the problems that you have often is here, that you can see you still have an overbite and an increased overjet, but you cannot really close it because there is an interference of the brackets on the lower incisor with the lingual surface of the upper incisor. This problem is a problem that happens if you try to achieve a good amount of overbite. If you close your patient with 0 millimeter of overbite, you will never have this, but you will also have a lot of instability. If you do this, you will have this problem if you use self-ligating brackets. With non-self-ligating brackets, we didn't have this problem. With self-ligating brackets, we are having this problem because they are thicker. And this is why we are shifting now to use mini brackets, mini self-ligating brackets, whose one of the bigger advantages they have is that in the area of the lower incisor they are much less thick, so you don't get interferences with the upper incisor. But this case is, of course, a bit old, and we used still the normal brackets, and so we had the problem. How to solve this? The easiest way is to place a retainer from 3 to 3 in the lower arch, remove the brackets on the incisor, and make the last phases of finishing without the brackets on the front in the lower. Here, this case is not finished to me yet. There is still a lack of intercuspidation here. And I think still that the patient is not ready for just finishing elastics. It's still too much. So we take another impression mounted in articulator, and we look if there are posterior interferences. And look at this. I'm going to introduce you this one, that is the pre-contact on the distovestibular cusp of the upper second molar. Please remember it, because you will see it very often. And if you start to take impression with articulator mounting on your patients, you will see it in the majority of your patients. I will explain to you why it is like this, and why would we have this so often. For now, just know that this is one of your problems of which maybe you are not aware. Once that this is taken care of, you can achieve a good occlusal result. What about the face of the patient? There was an improvement. This is before, and this is after treatment. Of course, a part of the improvement is that she learned how to use makeup, and that is not up to me. I don't teach that to my patients. But what about what I can work on that is not makeup is the lips. You can see that this was a non-extraction treatment, but despite that non-extraction treatment, you can see that before there was much less curl, this S definition of the lower lip, and therefore, even in a non-extraction treatment, you can improve lip competence by using vertical control. These are the superimposition on the stable structure that showed the effect of treatment. This is 2 years after the end of treatment, to show you that she stopped, unfortunately, using makeup again. But, of course, the extraoral appearance is still stable. What about intraorally? We still have a very stable result. And this is what is important to also check what happens after the end of treatment. The use of mini screws you can find in so many courses that is not particularly interesting for me to show you. I will show you later a patient in which I use mini screws to control the vertical and the lower. Another thing that you may want to know is in some patients you don't need to extract teeth. In some patients you don't need to use bite blocks. You just need to keep the force level very low. So you have to use light forces and be very careful in leveling. This is one of my patients. She is not on drugs, if you are asking yourself that she's too young. And this is how she looks like. She looks a bit better than the other patients, because you can see that she's got a little bit of strain in the mentalis muscle and the lips, but not so much as the patient before. However, still, also with her, we have a rather bad prognostic indication of the growth. She's a little bit a vertical grower. So we may think that she is going to develop even more vertical than what she is now. So we have to take care a little bit. But we can say it's a bit less severe case than the previous one. Intraorally, this is the situation. There is some crowding, especially in the lower there is marked crowding with impaction of one premolar and an incisor that is totally blocked out. It was decided to remove this incisor because this one is so much out of bone that even leveling it into arch would have a very bad prognosis.